Welcome to the fourth module of the Clinical Faculty Pedagogical Knowledge for Undergraduate Medical Education program. We will be discussing how clinical educators assist their learners through mentoring and advising. After completing this module, you will see how, as part of your identity as a clinical educator, mentoring and advising is a natural extension of your role as a clinical educator. There is a continuum between curriculum and how to use teaching strategies, assessment and providing feedback, and mentoring. In this module, we will explore evidence-based approaches to mentoring and advising. We will consider how the culture of medicine influences our learning environment and how we can help our learners adapt to challenging clinical situations. This module begins with a discussion of mentoring and advising for clinical educators. Next, we consider the culture of medicine and the hidden curriculum. We will explore how we may help our learners understand mindfulness and resiliency. Finally, we will review what the literature offers when we and our learners face uncomfortable situations in clinical settings. Mentoring is crucial to the progress a learner makes as he or she becomes a competent professional, as described by Ramani et al. In 2006. Unfortunately, few educators have benefited from mentoring and few have been prepared to act as mentors. We usually think of mentoring and advising as a function of the medical school where individuals are appointed and trained to assist our learners over the course of their medical school careers. While this is true, many of our learners benefit from mentoring and advising on clinical services in real time, guided by their clinical educators. Learners can benefit if clinical educators have some understanding of mentoring and advising. Educators who have functioned as mentors report a higher level of career satisfaction compared to colleagues who did not mentor. However, clinical educators are at risk for inadequate mentoring in their careers as well, as described in Ramani et al. 2006. Dalgatti et al. In 2016 describes mentorship in medical education as beneficial to the role of clinical educators who act to support learner success and prepare learners for their future in the realities of clinical practice. Mentorship promotes personal confidence and capabilities in learners, establishing and supporting a sense of self-efficacy as described within the social cognitive learning theory. The transition from a medical student to a first-year resident is a major challenge for our learners. Ramani et al. 2006 describes a study of 43 clinical education leaders. Participants enrolled in a workshop that explored types of mentorship programs, measures of success and challenge in mentorship relationships, and mentoring programs. The workshop evaluated the influence of gender and cultural differences in mentoring relationships. The 12 tips are presented for institutions to consider developing mentorship programs. However, there is much in this qualitative study and review of the literature that can guide individual clinical educators and how they approach mentoring with their learners. Romani et al. Describe characteristics of mentors that are shared with the characteristics of clinical educators. To be a clinical educator, one is first a knowledgeable and respected healthcare professional that is recognized by learners as a content expert. The content expert then adds interest in his or her learners and in teaching. Listening skills, familiarity in learners' capabilities, limitations, and interest in the future careers of learners are important characteristics of educators and mentors. Clinical educators often motivate learners and advocate for learners when other pressures limit learning opportunities. As evaluation and feedback are part of the educator and learner relationship, the educator is available and responsive to his or her learners. An informal mentoring relationship often emerges. Clinical educators should be aware of the differences in gender and culture that exist between themselves and their learners. Romani et al. In 2006 state that an educator acting as a mentor does not have to match the gender or culture of his or her learner, but should be an option if the learner wishes it. When an educator and learner do not share gender or culture, then the relationship should be free of discrimination. Gender and cultural differences can foster growth and understanding between an educator and learner as they learn about each other's perspectives. Clinical educators should reflect on their own gender and cultural bias to overcome innate prejudices and become more comfortable working with learners of different backgrounds. Along with supporting learners, clinical educators should also challenge their learners. Challenge promotes a learner's professional development and growth. Clinical educators that act as mentors balance support with challenge by providing learning opportunities that set positive expectations. Clinical educators that act as mentors should also be aware of their limitations, supporting learners, and be aware of what resources are available within the medical school for learners in need of support beyond the capacity of the clinical educator alone, as described further in Romani et al. 2006. Bhutan Foster et al. In 2008 defined culture as the integrated patterns of human behavior that combine language, thought patterns, communication, actions, customs, beliefs, and values. Included within the social construct of a culture are groups and institutions that reflect these collective patterns. Bhutan Foster et al. Continue to describe the medical profession as a culture with its own defining characteristics of language, thought processes, styles of communication, customs, beliefs, symbols, social groups, and institutions. Understanding the medical profession as a culture will guide clinical educators as they mentor their learners within the medical professional culture. The culture of medicine is often learned through observation and role modeling, following principles discussed in social cognitive learning theory. Often there is little formal preparation for learners to understand or become part of the culture of medicine, as observed in Bhutan Foster et al. 2008. Clinical educators can be helpful to learners that are grappling with the positive and negative aspects of the culture of medicine as learners move through their clinical educational experiences. The white coat can be a symbol of authority and responsibility. Learners often need guidance in finding a balance between authority and responsibility as they work with patients. Doctor talk is shorthand for the way medical professionals communicate among themselves. Even when two medical professionals come from different cultural backgrounds, they can communicate in a manner recognizable to other medical professionals with common terminology and structuring of speech patterns. Helping learners balance use of their developing medical language skills and yet be able to explain medical issues in a way understandable by patients and family members is one example of an area where the clinical educator can offer feedback and mentorship. The physician's explanatory model is centered on how medical professionals perceive an illness from diagnosis to treatment. Educators can provide feedback and mentor learners who are aligning the physician's explanatory model with what the patient or the patient's family understand about an illness. Bhutan Foster et al. In 2008 described the culture of medicine and how learners rarely have a formal introduction but rely on observation and role modeling, as in social cognitive theory. An aspect of this informal process is the hidden curriculum, which is an implicit guide and defines certain customs, conduct, and rituals in the culture of medicine. Hafferty in 1998 discussed the importance of recognizing the hidden curriculum and the learning environment. Hafferty questions the emphasis on change at the level of a medical school's curriculum when considering how medical students are prepared to become physicians. With a focus on the learning environment, attention is shifted from what learners are taught to what learners are actually learning. An alternative framework includes three components of medical education: the formal curriculum, the informal curriculum, and the hidden curriculum. The formal curriculum is described as the "this is what we do" curriculum that is defined as the formally structured and documented institutional curriculum. The informal curriculum is the largely spontaneous, highly interpersonal form of teaching and learning that occurs between clinical educators and learners. The hidden curriculum is more challenging to describe. It can be the behaviors that influence function at the level of the organization and its culture. The informal and hidden curricula are not documented but identify the differences between what learners are taught versus what learners actually learn. The informal curriculum describes learning at the level of interpersonal interactions with others within the learning environment in areas away from patient care, such as the elevator, conference room, corridor, lounge, cafeteria, etc. These interactions further define the clinical educator as a role model and mentor for learners, as conversations not directly related to the care of patients can be undertaken with some level of privacy if the area for conversation is appropriately selected. The hidden curriculum includes the structural factors of the learning environment that impacts the learning process. The hidden curriculum highlights the commonly held language, vocabulary, customs, attitudes of the taken for granted aspects of what goes on within the learning environment. Clinical educators need to be mindful of this aspect of the learning environment to be sure that they are modeling appropriate attitudes for learners regarding patients, other healthcare professionals, staff, etc. A clinical educator can think about the hidden curriculum starting with something simple as reflecting on what are the slang terms used in his or her clinical practice space that learners hear and then use. Next, we are going to consider what mindfulness and resiliency can contribute to our perception of ourselves as clinical educators and what that perception can contribute to our roles as mentors for our learners. The medical profession and medical education are very much interested in how mindfulness and resiliency are developed and experienced by medical professionals, clinical educators, and learners. Mindfulness and resiliency can provide skills that may prevent or reduce compassion fatigue and burnout. Healthcare professionals who are self aware are more likely to participate in self care activities and manage stress better. Healthcare professionals that attend to their own wellness are in a better position to foster wellness in their patients and their learners. The medical education literature presents programs for institutions to develop and deliver wellness and resiliency building programs for professionals and learners. Here we are taking an opportunity to mention how you, as a clinical educator, may be able to help at least promote mindfulness and resiliency among your learners based on your own experiences as part of your role as a mentor. Dopkin and Hutchinson in 2013 offer a detailed introduction to mindfulness. The article opens with a quote from William Osler in 1899, who said, quote, "Engrossed late and soon in professional cares, you may so lay waste your powers that you may find, too late, with hearts given away, that there is no place in your habit-stricken souls for those gentler influences which make life worth living." End quote. The tendency for healthcare professionals to allow the demands of their careers to eclipse their humanity seems an old problem. Research has been ongoing since the late 1990s on the role of mindfulness in medical practice. Epstein and colleagues have described the goals of mindfulness to reflect practice with the characteristics listed in this slide. Habits of mind that encourage, quote, attentive observation, critical curiosity, a beginner's way of thinking, and presence, end quote, cultivates professionalism in medical practice. Mindfulness may prevent compassion fatigue and burnout, as self awareness encourages self care activities to improve stress management. Healthcare professionals, educators, and learners are at risk for stress, erosion of empathy, burnout, and attrition. The consequences include impact on individual well-being and threatens the delivery of optimal healthcare, as described by Wald et al. In 2016. Defining and building resilience involves the professional duty to offer patients compassion and support even when circumstances are difficult for the patient and have emotional impact on the health professional. It is important the patient is provided comfort and support even when a patient is expected to suffer a detrimental outcome. A healthcare professional should be empathetic, but also recognize his or her feelings of helplessness when not able to offer treatment or relief. A clinical educator can describe his or her approach to interacting with patients in difficult situations. Being present and listening is often all that a healthcare professional can offer. How a clinical educator processes the experience will help a learner make sense and find meaning in an experience. Try not to load the learner with data, but help the learner understand there are tools for understanding the many facets of a difficult clinical situation with a patient. The clinical educator also acknowledges that he or she and his or her learner will experience emotional responses along with the patient. Compassion fatigue and burnout are common concerns throughout the medical profession in the United States. The incidence of compassion fatigue, burnout, and professional attrition is high among many types of healthcare professionals. Oncology nurses are at high risk for these issues, as described in Potter et al. 2010. Compassion fatigue, vicarious traumatization, and secondary traumatic stress are other terms used to describe the emotional impact on healthcare professionals working with patients in trauma medicine, as described by Nimmo and Huggard in 2013. Compassion fatigue is defined as a diminished capacity to acknowledge the suffering of others. Vicarious traumatization describes the outcomes of working with trauma victims where healthcare professionals have an excessive, unhelpful, empathetic response to trauma victim suffering. Secondary traumatic stress is defined as destructive emotional distress resulting from an encounter with a patient that inspires fear related to the professional's own safety. As clinical educators, we are at risk to experience these emotional responses and may see these emotional responses in our learners. Dyrby et al. In 2014 defined burnout as a syndrome that is caused by work-related stress with symptoms including emotional exhaustion, cynicism, and detachment related to patients, and a low level of personal accomplishment. Burnout is a problem as it can reduce professional behavior, contribute to medical errors, lead to thoughts of self harm and suicidal ideation, attrition, relationship difficulties, and substance abuse. Medical schools and residency programs have responded by providing wellness programs and by reducing work hours when possible. In this national survey study of medical students, residents, fellows, and early career physicians who have been working less than 5 years out of training, the incidence of symptoms related to depression, suicidal ideation, low sense of personal accomplishment were highest among medical students and reduced incrementally as the participants' careers progressed. For residents and fellows, overall burnout, sense of detachment from patients, and high fatigue were prevalent. Among early career physicians, emotional exhaustion was most prevalent. All categories of distressful symptoms were highest during medical school and residency or fellowship. If you are aware of these issues in yourself and your colleagues, then you can be sensitive to picking them up among your learners. Your mentoring may be a crucial first step for one of your learners to recognize and seek help for a problem related to these all too common issues in our profession. When we think about how clinical educators mentor learners, the question of mindfulness, resiliency, and burnout must be considered along with our learning environment. Cook et al. In 2014 described how mistreatment among medical students contributes to burnout. Medical student mistreatment is a decades old problem that can adversely impact our learners both personally and professionally. Medical student mistreatment was compared to child abuse by Henry Silver in 1982. Burnout, as a separate consideration, is known to have a negative impact on medical student experience. Mistreatment includes issues related to gender discrimination, racial discrimination, physical intimidation, and public humiliation. Sources of mistreatment include faculty, residents, nursing staff, ancillary staff, and fellow students. Medical student mistreatment has negative effects on learner well being and can impact professional choices. Mistreatment correlates with emotional and mental health issues, including substance abuse, decreased self esteem, and depression. Mistreatment is associated with dropping out of medical school, low career satisfaction, regret having chosen a career in medicine, and lower likelihood to choose a career in academic medicine. When mentoring our learners, we should be aware of how their time in our learning environment may be affecting their experiences and take steps to be sure mistreatment is not part of that experience. To conclude this module, we will consider specific mentoring situations that come up occasionally during our practice as clinical educators. These situations include learners seeking advice about how to study, dealing with patients and families that discriminate, and observed perceived unprofessional behaviors in the clinical environment. Larson et al. 2012 studied how medical students engaged in three topics of clinical interest. This investigation compared three different learning activities: testing with standardized patients, testing with written examinations, and studying a review sheet. The important outcome that can help clinical educators assist their learners who are preparing for formal testing is to recommend repeated testing rather than studying notes in preparation for standardized testing such as National Board of Medical Examiner subject examinations or the shelf exams. Clinical educators can offer this as evidence-based advice to their learners who ask about study strategies. Repeated retrieval practice available from test question banks is in combination with real or simulated clinical experience is superior to studying content alone. Educators should remind their learners that the medical school provides support for shelf preparation and other forms of testing. Larson et al. 2013 conducted another study at Washington University in St. Louis, Missouri. This study reinforces how repeated testing that is interleaved or presented in no specific order that requires effortful recall is an evidence-based approach to studying. This approach helps learners build long-term retention of content with understanding. Self-explanation is a process where learners generate an understanding about how and why a piece of information is important and how it fits into existing knowledge. Self-explanation enhances and reinforces the scaffolding learners need, employing the social constructivist learning theory. For clinical educators mentoring learners, these studies provide evidence that repeated testing, augmented by clinical experience and self explanation, can help learner performance in long term retention and understanding complex content. Repeated testing alone is not as effective as repeated testing with either clinical experience or self explanation. These methods to study are superior to simply trying to memorize the content. Clinical educators can offer these study strategies as evidence based advice to their learners when asked. Educators are again reminded to be aware of resources available for learners in this medical school. Learner mistreatment continues to be a major and serious issue in medical education. Mistreatment of learners by healthcare professionals has been studied extensively in the medical education literature. National organizations in medical education and institutions have policies and procedures for reporting and responding to incidents of mistreatment undertaken by healthcare professionals against learners. Mistreatment of learners by patients or their families has not been studied widely and would be difficult for a teaching hospital or medical school to formulate policies and procedures to address when learner mistreatment occurs by patients and families. Whitgobe et al. In 2016 identified strategies that clinical educators and learners can consider when responding to mistreatment by patients and family members. This table is modeled after Whitgobe et al. 2016. The themes and possible responses listed above are general and applicable to a wide variety of clinical situations. The clinical educator may find him or herself called upon to provide mentorship and advising for a learner facing an extremely difficult situation. When a learner and an educator face this situation, it is essential the educator take a leadership role that assigns importance to protecting the learner while navigating how to provide the patient with appropriate and necessary medical care. The themes outline larger questions such as how sick is the patient? Is there an opportunity to form a therapeutic relationship that includes the learner? Is it possible to take the personal aspects of the encounter and focus on what the patient or the patient's family is actually saying when their concerns and needs might be? This is all done with an overriding goal of ensuring a safe environment for the learner. Sometimes these kinds of events are a clear directive for educators to remove learners at risk for harm, while other times there are opportunities for all, the learner, staff, patients' family members, and the clinical educator, to deepen their understanding of how patients and their families will express themselves as they seek medical care. Understanding does not imply endorsement of unacceptable behavior. All on the clinical team need to understand the difference, including learners. Whitgobe et al. 2016 identified steps clinical educators can consider when a learner encounters discrimination from a patient and or his or her family. When a learner experiences discrimination, a debrief is a useful strategy to review with the entire healthcare team as an opportunity to analyze and understand what happened. A debrief will help assure that the learner is safe in his or her learning environment. A debrief will also provide an opportunity to explore how the clinical educator and the clinical site will respond to similar experiences in the future. The last recommendation is for the clinical educator to reflect on the experience, working with the learner, the patient's family, and the clinical setting. Clinical educators should consider exploring their experience in verbal or written form with attention to personal boundaries, their own biases, and what triggers may produce an emotional response based on the educator's own experience of discrimination. Clinical educators are strongly encouraged to seek the counsel and support of colleagues in these matters and certainly involve the educational program, the departmental, and institutional leadership as needed. Patient safety is a major focus in medical education. Healthcare providers understand the importance of contributing to a culture of safety to avoid patient errors and harm by speaking up. Learners are included among healthcare providers that can report situations where unprofessional behavior occurs. Wong and Ginsburg, 2017, understand unprofessional behavior as a threat to patient safety. Learners see more examples of unprofessional behavior compared to direct threats to patient safety. Learners are more likely to report direct threats to patient safety compared to unprofessional behavior. Reasons for this difference is not clear, but may be related to a learner's fear that reporting will alienate the team and provoke retaliation. Clinical educators may find it helpful to consider these points when a learner brings up having observed unprofessional behavior or a patient safety concern. What a learner may perceive as unprofessional or dangerous may be seen in a different light depending on the context, how professionalism is defined, and how the question of unprofessionalism expectations is framed. There is a range of opinion in understanding the immediacy of a professionalism concern. Wong and Ginsburg discuss the differences when a learner observes someone in an operating room contaminate a sterile field versus another learner who observes a member of the team not paying attention during rounds. Unprofessional behavior such as rudeness or intimidation can contribute to a higher incidence of problematic medical or surgical outcomes. Strategies that may help clinical educators include the CUS approach, where C is concern, U is uncertain, and S is safety. A concern is the mildest level, where a threat to safety is the highest level requiring immediate attention. The ARCC approach includes A as in ask, R as request, C is concern, and the final C is chain of command. In this schema, asking is lowest level while an appeal to the chain of command is the highest level that again requires immediate attention. Clinical educators can help learners think about incidents of unprofessional behavior, including how urgent does the event seem, what is an appropriate level of concern, and what is the time frame for reporting. Clinical educators have opportunities to mentor and advise learners informally while teaching. Mentoring is an important part of professional identity development where educators act as role models and advisors. Social cognitive learning theory informs this aspect of the mentor-learner relationship. Mentoring involves skills such as listening, giving feedback, providing motivation, and advocacy for learners. Educators can advise, motivate, and advocate with an understanding how the culture of medicine and the hidden curriculum affects learners and their learning. Educators can help learners develop mindfulness and resiliency awareness. Learners benefit from understanding compassion fatigue, burnout, and mistreatment. Depending on circumstances, educators can mentor and advise learners with study skills, discrimination from patients and or family members, or dealing with witnessing unprofessional behavior. Mentoring and advising, even when informal, is also strongly grounded in social constructivism as the educator deliberately builds a learning environment that recognizes a learner's previous knowledge, developmental level, and skill set, and then builds new knowledge and skill in the zone of proximal development.